Morning, everyone. Welcome back. Monday, 10 o'clock. These are coming around really quick. I've really enjoyed putting this session together. It's all about the spinal disc. So we're going to do a little bit of a recap of the ligaments. Just bring up my comments there. Morning. Happy another Monday. Look, we should hopefully have a few on that can't usually make it because it's bank holiday today. We've got a session all about the discs. Going to recap the ligaments and going to talk a little bit about pathology of the discs as well. So how they get injured, how they age, that kind of thing. So right, okay, let's have a look. I'm just trying to work out what this says. I have no idea. So, that's very. I wouldn't even try to say that. I'm really sorry. Morning, Sarah. I don't want to do it any disjustice. That's the thing. Yay, good, cool. Yeah, so it should be up to date. Brilliant. One of the ligaments that we talked about last week is going to be crucial for today as well. I did kind of allude to it last week. So let's get going. If you got any questions along the way, then obviously just give us a shout. So we looked at these. Just rearrange my screens a little bit. That's a bit better. So we looked at these structures. So this was on the looking at the back of a vertebra. So there you're looking at the kind of inside of the back. So this bit here is the lamina. These are the pedicles, and then we've got this ligamentum flavum, which it prevents hyperflexion, and often will become injured in things like road traffic accidents. So if you have a sudden kind of like whiplash type movement, that can open up that back of the spine, which then can cause a injury to the ligamentum flavum, and then as it heals itself, it then starts to grow, so you get ligamentum flavum hypertrophy. And because of where it is, so just in front of here, if you imagine the line all the way down here, that's where your spinal cord will be. So if you've got an injury to the back of the vertebral canal, then it can start to encroach on the space that the vertebral cord has available to it. So that's the ligamentum flavum. And then this was an overview of pretty much all of them. This is a side-on view. So if you imagine looking at someone from the left, looking into their spine, obviously if they had no other tissue in the way. So this is the vertebral body. Then you've got the disc, and obviously we're going to be talking about this structure in a lot more detail today. Then you've got this area around the vertebral body, which is the cortical bone, and then we've got this spongy bone in the middle here, and that's going to be important for today as well. Again, we've kind of touched on it before. The ligament that we're really interested in is this one here that runs all the way down the back of the vertebral body. So this is the posterior, because it's at the back, longitudinal, because it's really long, ligament. And we're going to have a look at it again on some of the videos today, but if you remember, it runs all the way down the center of the vertebral bodies and over the vertebral discs, and then fans out a little bit as well, so to cover the kind of sides of the disc. So it's a bit of a kind of support structure at the back of the spinal column, so of the vertebral bodies. So that's the one we're going to be really interested in today. We also looked at these. So these are the interspinous ligaments. So these are in between the spinous processes, and then this one here, which is the supraspinous ligament, so superior to the spine. Okay, so these ones we can feel. So supraspinous ligament, when we're palpating someone's spinous processes, you will be over those ligaments. You won't be able to distinguish which tissue you're on, but those will be the kind of things that you'll be pressing on. And then this one at the front was the anterior longitudinal, so wrapping around the front of the vertebral bodies. So that was a bit of a recap of last week. 45 minutes in 1 minute. Let's have a look now at the discs. So yeah, we've got a whole session on discs today because I think one of the things that people get really freaked out about when you see them is an injury to the disc. And we've probably, even if you've not had any back problems before, you've probably heard of someone that has, or had clients in or patients in that have had disc issues. And we've got this kind of preconceived idea about what happens to a disc when it gets injured. So just going to go through some of the structure in a bit more detail, because we've covered it a little bit, but not in any great depth. And then how it gets its nutrients, and then how over time it will start to age and change, and also what happens after you've had an injury as well, because a lot of people think that, oh, I've had an MRI, it's shown an issue with the disc, and then that's kind of how it's left. And what we've found with the recent literature is that these discs can reabsorb, and without really doing anything very special. So sometimes they completely reabsorb after about 9 months to about a year. So there is hope for people who have these issues. But interestingly, even if they have reabsorbed, it doesn't sometimes change their pain. So the disc protrusions, the disc herniations, whatever, and we'll go through the classifications of those. They don't correlate with pain very well. So it's again, it's quite interesting. Okay, so this kind of session will help with MRI reports, and when you're looking at if you do get to see MRI reports from your patients or your clients. So what do discs look like? There are, obviously, we're doing a whole session on discs today, so there's not loads of videos to show you of all different parts. There's one video and that's it. So there is a lot of me warbling on today, so apologies in advance, but we'll I try and make it a little bit fun for you, and ask obviously any questions as we go as well. So just move me up there. So this is a side-on view of a disc. Okay, so if you imagine it being cut down through the middle of the vertebral bodies, so that will be a vertebral body there, that will be one there, and then this is the disc in the middle. This section here, this is the nucleus pulposus, and you can see it's a different kind of structure to the outside. So we've got an anterior annulus fibrosis, so this section at the front, so this will be towards the front, and then a posterior annulus fibrosis just here. Okay, then we've got these things called end plates, and we've talked about those before. So the top and bottom of the disc and the vertebral bodies, they're connected to each other via these end plates. Okay, so it's like a cartilaginous join between the disc and the vertebral body. Absolutely solid. Okay, so it's all really solid. And you can see in here the annulus fibrosis has got these it reminds me of the concentric circles of a tree. You know, if you have a look at a tree stump and you can see the circles, the rings around, it's very similar to that in terms of how it looks. And the way that it's designed is in lots of different directions. So you'll have one layer going in one direction. The next layer, the next ring around, will be orientated in a different direction. The next one will be orientated in a different direction, and that makes sense, because if when you move and twist and turn your spine, if all of the circles were going in one particular direction and then you went in the opposite direction, then it's more likely to cause an injury. So all of these layers are in different orientations so that it can cope with the stress a lot better. Obviously, something that's developed over time. So so that's the kind of inside of your discs, and this is how the disc gets its nutrients. Let me just move that out of the way. got a bit more room. There we go. Okay, so on the left-hand side of the picture here, it's zooming into this bottom section of bone. Okay, so this bit here. So there's your nucleus pulposus. These are the annulus fibrosis. So annulus means annual. Yeah, so like all year round. If you think that's why it's called annulus. Fibrosis because it's fibrotic. Yeah, it's fibrous tissue. So we've got these annulus fibrosis rings here, then the edge of the bone, and that's the end plate section there. So this is zoomed in. So you can see here we've got the nucleus there. Then you've got the cartilaginous end plate. Okay, so that's the cartilage bit of the bone that connects into the disc. Then you've got the subchondral plate. So chondral, anything with chondral in means cartilage. So subchondral means underneath the cartilage. So we've got this layer underneath that cartilaginous end plate, the subchondral plate. If you have a look in there, that's what it's got lots of little capillaries in that area there. And then you've got the blood vessel that's in the bone just here. And that is how the disc gets its nutrition. Okay, so the disc itself doesn't have, other than the outer parts of it, doesn't have a blood supply. So the nucleus in the middle doesn't have a blood supply. It gets its nutrition from the bones, okay, above and below. So the cartilaginous end plate is a thin plate of hyaline cartilage lining the vertebral bodies at the disc. So that is that section just there. Okay, so basically in between the end of the bone there and then the nucleus just there. So it functions, its function is to prevent the well-hydrated nucleus pulposus from bulging into adjacent vertebra. So it creates a bit of a barrier so that the nucleus, so when you put load through the disc, it doesn't just push up into the vertebral body. So there's like a hardened layer, but it's not like a plate. I think I've put that down here. I might be on another slide. It's not like a plate. It's more like a filter. So it's like a filtration system rather than a solid, because end plate doesn't really say what it does. Okay, it's a bit annoying in that respect. You'd imagine that an end plate would be just a solid barrier, but it's not. It's got these a kind of porous network for you to be able to get nutrition through. So it functions as a pathway of diffusion for nutrients and waste products passing between the disc and the vessels located on the osseous or bone side of the end plate. So it's it's basically like a connection plate between the two. Okay, so that, and we did talk about this a little bit a couple of weeks ago about something called imbibition. And I use the analogy of a sponge. So if you have a bucket full of water and then a sponge, and you squeeze the sponge, put it into the water, and then let it go, then the sponge will soak up that water. And that's basically what happens and how your disc gets its nutrients. So when you put load through the disc, it will squish it, and then when the load is then released, it draws nutrients into the disc via the end plates just here. Okay. Yeah, kind of. Yeah, to act like a meniscus. Yeah, and they're quite similar in structure as well. So if you think about, if you go back to the knee videos that we did and look at the orientation of the meniscus rings and the layers, it's a very similar kind of structure. And also the outer part of the meniscus is the only thing that's innervated and the only thing that's got blood supply. So it's very, very similar, except obviously without the nucleus in the middle. So then you've got these annular rings, which we've talked about. So you've got the end plate on the end here, and then obviously these annular rings, and then the nucleus in the middle. So the annulus is an outer ring, so like the concentric circles of a tree, and it's got between 10 and 20 layers. Okay, so that there aren't actually that many. I when I was doing a bit of research for this and getting some figures, I was quite surprised at how few there were. And so between 10 and 20 of these concentric rings that wrap around that nucleus, and they're in a layered arrangement in all different directions. So the annulus resists tensile forces produced during bending and twisting of the vertebral column. So if you imagine you've got load coming through this area, load coming up there, and it's a bit like having a balloon that you've got on a table, and when you push your hand onto the balloon and the table is underneath, then the balloon starts to change shape to withstand the forces that you're pushing through it. And then as you move the hand over the top of the balloon, that will change the direction where the forces are distributed. Okay, so it's I think that's a nice analogy to kind of to say what the disc does. So the outer rings of the annulus are the only disc structures that are innervated, so they're switched on. Basically, they've got a supply of sensory neurons. So it's only that outer portion of the annulus that has a sensory nerve supply. Okay, so any changes in the middle of the disc will go largely, depending on what has happened, will go largely unnoticed because there's no sensory nerve supply there, so you won't know that it's happening. There we go. Cool. So this is a good picture. So again, similar to the structure of the meniscus, where when it's all in different directions. So you've got the nucleus in the middle, and then these rings. Remember, 10 to 20 of these rings wrapping around that nucleus pulposus, all in different directions, so that it can withstand forces. And I like my food analogies. Well, one of them's not food, but you get the idea. So it's a bit. The nucleus is a bit like porridge. It's that kind of consistency, or like you've hocked up a big bit of phlegm. Okay, so if you're not from the UK and don't understand that, it's Google that. I'm not doing an impression. So nucleus pulposus is a well hydrated, so it should be well hydrated, amorphous, so there's no clearly defined shape. It is a bit different. It's a bit like a blob, okay, in the middle. Substance containing a small percentage of randomly orientated collagen fibrils. So we've got these, just a mishmash of network with a kind of like a phlegm center. Nice. Get those ready for Easter next year. Okay, so how does the disc deal with forces? So we talked a little bit about this just a second ago. So the main force that the disc has to react against is what we call an axial load. And that is a load. If you imagine all of your vertebral column all stacked up on top of each other and you squish it from the top down, okay, that's an axial load. So if you think about the weight of the body going through the vertebra, that's the main load that the discs have to tolerate. So we've got the normal disc here, and then as you get this axial load coming through the body, then the gravity will obviously push that down, and it will somewhat deform, if you like, the disc. But that's his job. Yeah, it's supposed to do that. So in terms of kind of mechanics, this is, if you Google axial load, then you'll come up with a load of pictures like this. So when you're pushing down on a structure, it gives in the middle and then it comes back again. Okay. Now, obviously, that will change in humans over time, because as we age, things will change. Sometimes, depending on what you do, the body is able to tolerate things better because you've consistently done the same thing. So your body gets the discs get thicker, okay, more hydrated. Where if you're very active, if you're quite sedentary, and then you do something where it requires axial load tolerance, then sometimes your disc is not so happy because it's not used to that kind of force. So it literally is movement is medicine with these. So some of the things that can happen to the disc, if we have a look here, so that this is an X-ray of a vertebra, so you can see the vertebral body just there. There's the spinous process coming out the back. This is the end plate, and you can see a little bit of a dip in there, okay? And then that black bit there, that's where the disc is. So it's zoomed in here, see, and they've drawn around it, so you can see it a little bit more clearly. So this is called a Schmall's node. Schmall's node. Okay, so axial load is just distributed into the annulus and the end plates. So as you push down, it squidges out, but then obviously the annulus is going to take that force as it comes out, and it will also then push material up into the end plates. And what can happen is you get these little like fissures, okay, these little kind of bits of damage really into the end plates, and a bit of the nucleus can go into the vertebra above or below. Okay, so in this particular picture it's gone above, in this image here it's gone below, just there. So the annulus is really good at dealing with those forces, but the end plate is not so good at it. Right? The end plates are more likely to give first with increased axial loading, but again, these kind of things can be entirely normal, and also you don't know you've got them. Okay, so there's plenty of these kind of things where we just don't know that they're going on. So the nucleus in this case has herniated upwards or downwards into the vertebral bodies. And that's not what you normally think about when you think of a herniated disc. You think of it coming out the back. Yeah, but sometimes you can get these Schmall's nodes where they come out the top or the bottom and push into the vertebra themselves. Okay, so here's just an image of that. So this is a normal disc. There's your nucleus. You've got the end plates just here, the annulus around it, and then obviously on this one, there's been a bit of a kind of protrusion into the vertebral body. Okay, just there, and that's your Schmall's node, and that's what it will look like on an X-ray. Okay, so there's your first kind of herniation that you might not have heard about before. So the way that discs are often talked about is, oh, just seen your comment there. feel that when you go back to running, yeah, definitely, yeah. You it's weird because when you first start doing exercise, or you start doing, because we've been running a couch to 5K program, and people are getting lots of little niggles and stuff, and it's all about, keep going, because if you keep doing it, then obviously back it off if it's too much. But if you keep going, your body will adapt. Your body will be able to cope with these forces a lot more. And actually, running is great for disc health. It's really, really good. And we know it's good for bone health as well, because of the studies with arthritic changes with those that are runners. We posted about that the other week. So recreational running is brilliant for bone health. And it's often thought that, oh, you're going to wear your knees away, you're going to wear your back away. Actually, if you're sedentary, it's worse. Yeah, you end up in a worse place if you don't move. And people are often worried about their discs because they are described like shock absorbers. And when I was training in the fitness industry, this is how I was told, or what I was told a disc does. But it doesn't really absorb shock. What it does, because if you think about it, that would then contain the forces going through it. But what it does is it distributes it amongst all of the different structures around it. So it's a distributor rather than a shock absorber. Yeah, exactly. Big Dan is a shining example of that. Yeah, I mean, God knows how many days he's up to now with his running. I think it's 170 odd, isn't it? But he does it really, really sensibly. So if he's having a bad day, he just won't do as much, but he still wants to get out there and do a bit. And if he's having a good day, then he does a bit more. And that's exactly how it should be. You should adapt it to how you're feeling. So when we move around, I will show you a video in a sec. This is really interesting, I think. So when we move around, this is what happens. So obviously we've looked at axial loading and coming through, and then the annulus and the end plates take some of the force of that loading. But obviously we don't just move up and down in a straight line. We turn in different directions. So when you apply load to the vertebra in different positions, you will stress different sides of the disc in different ways. So if we have a look at an extension movement here, so this is the vertebral body, and it's as if you're leaning backwards, so you're squashing this part of the disc here, and then stretching this part of the disc here. Okay, and then if you're which is a bit weird, because what the way it's taught, and I remember this from like manual handling stuff. You know, they often use a donut, yeah, and they get a donut, and then they squish the front of the donut, and then all the jam comes out the back. Yeah, so it's showing that if you squish forward, jam comes out the back, and you think, oh, bloomin' heck, I don't want to bend forward then, because then that's going to create a herniation at the back. But if you have a look, it's actually the opposite, or the opposite is usual. It can happen that way, but the opposite is usual. So we've got an extension force here, but the nuclear material isn't being pushed forward. It's actually being squished backwards. Okay, so it does the opposite of what you actually think. So we're getting a stretch on the front of the disc, and then a bulge on the back. So the annulus is weakest and thinnest posteriorly. So yeah, you would expect a different result. Posterior annulus is also less pliable, so that's why we do often get injuries out the back of the disc. Flexion causes an anterior bulge, so when you bend forward, it stretches the back of the disc and squishes and pushes out the front, which is not what you usually think. And then when you go into extension, usually it's a posterior bulge. So as you go backwards, you stretch the front part of the disc and squish the back, and that's what causes the posterior bulge. So it's extension, usually, not always, rather than flexion, that causes those posterior movements of the disc material. So this is not always the case, and it will depend on different pathologies and morphology. But I've put there a bit weird because we often think, okay, like the jam donut, you squish the front, it comes out the back. Actually, it's more likely to be the other way around. Okay, right. Let's have a look at a little video. Enough of me warbling on a bit. So this is vertebral body. This is your disc in the middle here. These are your transverse processes, body and disc just there. So let's get this going, hopefully. Yay, it's working today. So vertebral disc in the middle, vertebral body here, and then these are the intervertebral foramen. So we're going to obviously bring in the nerves as we go through. And we'll talk about how the disc impacts the nerves when we do the nerve section. So this is what a disc will look like. So you can see those rings around the disc just there, and then this kind of mushy phlegm bit in the middle, which is the nucleus pulposus. So there's your annulus, there's your nucleus, bit squishy. So it's not like liquid, it's kind of squishy collagen. So obviously permits movement. And then those are your intervertebral foramen just here. Okay, so that's where your nerves will eventually come out. So the nerve roots will come out of there. So that's basically what a disc looks like. So hopefully bringing all of this into a bit of life. Cool. So when I was learning osteo, we basically got told that if you bend forward and it's painful, then it's a disc. If you bend backwards and it's painful, then it's a facet that you're irritating. But that is just way too simplistic. And also, if you think about the biomechanics, what we just talked about, when you bend forward, so you have an anterior wedging of the disc, it actually bulges forward. It doesn't come out the back, or less likely to come out the back. So this kind of thought process just doesn't make sense. It's not logical. And also it's just way too simplistic. And there's lots of other things that can, if it's a mechanosensitivity, so the structures are causing some kind of irritation, you've seen all of the structures that are around the spine that could be nociceptive, so they've got some kind of irritation around that area. Yeah, it could be loads. And then that feeling, that nociceptive feeling, can be amplified if you are scared witless about moving. Okay, so everything else then goes into spasm to stop you doing things. So it's yeah, we've got to stop thinking about the body as if it's a piece of Meccano, and oh, if it's this then it's this, and if it's that then it's that, because it's just way too simplistic. Yeah, I think that kind of thought process, I think, sets therapists up to struggle, because if you're saying this to your patients because that's what you've been told, and then they come back with an MRI that shows something completely different, then it makes you look a bit silly, and it's not your fault. It's just the way that we've tried to drill down with things. Then yeah, it's not as simple as that. Yeah. No probs out. No worries, mate. Good to have you in. Tight. Yeah, that's really good. Yeah, I'll have to get some some pictures of that next time. So bending over muffin tops. Yeah, that's good. Yeah, I like that. Okay, so how does and this is normal, by the way, what I'm going to show you now. So don't worry about it. This is normal part of the aging process, and I showed you the study. I'll show you it again, of the kind of changes that we see within the disc. So the starting point of a disc herniation is to do with something called a radial fissure. So we've got these little kind of cracks in the annulus rings. So if you have a look, and remember, the posterior aspect of the annulus is the bit that's the weakest and less pliable. So we're more likely to have a posterior herniation or fissure at this point than we are anteriorly. Okay, so you've got the disc material in the middle, and then that first little annular ring has been broken through, and a little bit of disc material has leaked out. Okay, and then a grade 2, it's a few more. Grade 3, it's a few more, and then grade 4, it's pretty much to the end. Okay, so that this doesn't usually happen all in one go. Okay, this will happen over time, and this is quite common, because what you'll find is that people will come in to you in clinic, and they'll go, "I don't know what's happened, but my back's killing me, and I didn't even do anything," and it's because it will have taken a while. Yeah, it's not something that you, unless it's traumatic, it's not something that usually happens overnight or in one instance. If they do feel it in that one instance, it's usually the straw that broke the camel's back. So they've had these changes going on for a while, and then you probably heard it, or I just sneezed, or I bent over to pick up something, and then my back went. And sometimes that can be because of this, because on these outer edges, this is where we've got those sensory nerve fibers. So that's the only point at which they felt it, because that's the only bit that's innervated. So, these bits here, this has been going on for quite some time. And again, it's entirely normal. But then when it's got to a certain point, boom, and then that's when they felt it. So that's why people present like that. And that can be a bit concerning sometimes, because it's like it's come out of nowhere. But actually, it's been happening for a while. Okay, so the integrity of the annulus changes from the inside out. That's the way it usually changes. So the nucleus starts to creep through the layers, and that's what a fissure is. Okay, so that's the start. So how do they survive then, these discs? So we looked at the end plates before, and the nucleus pulposus, and that end plate cartilaginous layer, and then this subchondral bone where you've got the blood supply feeding that nucleus in the middle there. So only the outer few millimeters of the disc have a blood supply. Okay, so these outer few mils. So we have to get the nutrients through the bone. So the end plate is not closed off. The nutrients from the vertebral body is drawn into the disc via something called protoglycans. It's a good question there. Can it reverse? Yes. Yep. So if you have and weirdly, the bigger the herniation, the more likely it is to reabsorb. Okay, the smaller ones, they usually stay and they just hang around, but the bigger ones, they usually get reabsorbed, and we'll talk about that in a sec. That's a good question. Yeah. So yeah, we get the nutrients from the vertebral body, and it's drawn into the disc via these things, protoglycans. Okay, I'm not going to go into too much detail, but basically they are negatively charged. So what happens is when you've got something that's negative, it draws neutral and positive things towards it. So what happens to water, which is neutral, it gets drawn into the disc because of those protoglycans. Okay, and then that then provides the nutrients for these chondrocytes, which are cartilage building cells, to build the discs. Okay, so the protoglycans draw the water and the nutrients in from the bone, and then the chondrocytes start building the disc. Now, when you're younger, you've got loads of these and really, really healthy discs. As you get older, the builders get a bit older, and then they don't do as good a job. Okay, so that's why we get these normal age-related changes. You've also got this stuff here, matrix metallopectases. Nice one for a bank holiday Monday. So let's call them MMPs. So MMP in enzymes, these clear away the waste. Okay, so you've got protoglycans drawing in the nutrients, the chondrocytes building the cell, and then the MMPs drawing all the waste or taking the waste away. Okay, so when you're younger, this just pop me down there. You've got a lot of this, and these are quite active because the turnover is quite quick. So you've got nice healthy discs. Okay, so protoglycans are like your DPD van. They're delivering nutrients to your disc. The chondrocytes are your happy builders, and then the MMP enzymes are your bin men, bin people. Okay, and taking away the waste. All right, so protoglycans bring in the nutrients, chondrocytes building the cell, the disc, and then the MMPs taking stuff away. Right, so hopefully that makes all that make sense. So what happens when we get old then? This happens. So your delivery vans get fewer, your builders get old, and then your MMPs, your bin men, they increase. So the hydration of the disc is affected, and the structural integrity of the disc is also affected. So you've got less plumpness, for want of a better word. Okay, so and that's just normal. Yeah. So the delivery guys and the builders get old, but the bin men, they keep going. Okay, so you're actually turning over more disc than you are making. All right, and that's why we get these changes in disc height when you have a look at them on MRIs. So if you've got someone in their 80s, they're very unlikely to have much of a nucleus, and that's quite good because then it can't herniate. Okay, so it's only when you're younger, when the disc is nice and plump, that we get these issues with disc herniation. So as you progress into your older years, the risk of herniation becomes less. Okay, and then we showed you this before. This is from last week. So normal changes, your discs get bigger and thicker, so that's normal, unless you're really sedentary, and then it has the opposite effect. The end plates shrink when compared to the rest of the disc. Okay, so if you think about that, if the end plates are starting to shrink, you're not able to get as much nutrient to the nucleus. Okay, we are all just becoming prunes. Yeah. It's harder to get nutrients to the disc, and as we get older, the annulus does most of the force distribution. So your disc material is reduced. So then the annulus, those rings around the outside, they have to absorb a lot more of the load. Okay, but as I said, old discs are less likely to herniate. Yay! Okay, light at the end of the tunnel. This has been our hashtag for years in our clinic and in our education. So movement literally is medicine. Discs love movement. Yeah. So, and the problem we have with people who have disc issues is that they're scared to move. So, if we can get them moving in a way that they feel comfortable, it's going to have a real big benefit to not only their mental health and how they feel about their back, but also the physiology in their spine. Okay, and that is a really important message to get across. Yeah, I've got bits of my head disappearing. Um, my lighting's gone a bit awry, I think. Hold on. Which way's worse? Oh, that might be better. Yeah. How's that? That's it. Oh no, it's still there. I think I've just made it worse. So we said this before. So healthy discs if you move. If you don't move, you'll have less healthy discs, and that's from this paper here. So you can have a look at that if you want to. This is really key. So just because someone's old in terms of calendar years, it does not mean that their discs are old. Okay, so your lifestyle can change how your discs look on an MRI, and it's very, very similar to. I mean, genetics plays a huge part in this. So if you have a genetic predisposition to disc issues, then unfortunately you can blame your parents, but also your lifestyle choices will affect the integrity of your discs as well. So if you've had a parent who has had disc issues, then a good way to counteract it and stop you getting it quicker is to become active. Yeah, so that's really, really important. Um, I'll answer that in a bit, Tris. Yeah, as we go onto this. So herniations. What time are we at? Yeah, cool. Right, I'll quickly go through this. So we looked at this before. These were the different fissures stages, so the radial fissures. So due to the slow nature of the radial fissures forming, you can often have symptoms and people have no idea what caused it, because it's not until right at the end that they actually feel something. Okay, and that can freak people out because they think, what the hell have I done? Even if, especially if it wasn't anything like major, you know, they had no fall, they were literally just bending over to tie their shoelaces or something like that, and you hear that quite frequently. So we need to just reassure people that it's not uncommon to have those kind of symptoms. So when you have a herniation and the disc material comes out of the annulus, so it's broken the seal. Okay, so when the annulus has been breached, protoglycans will go crazy. Yeah, because remember those protoglycans, those DPD vans, they get the nutrients from. So they draw water into the disc from the bone and from the capillaries in the bone. So now, if it's exposed to the whole spinal canal, it's just going to rush a load of water in. Okay, so and what can happen is the disc can actually double its weight within 4 hours of that herniation. Okay, so it will just go really, really plump. Yeah, so the protoglycans have a party and they suck in loads of water. So if you imagine that this dam here is the annulus, so there's been a breach in the annulus, so the protoglycans now in the disc are just drawing loads of water into the disc, and it will just plump up. Okay, that doesn't last forever. It will soon recede, but it can grow quite quickly within 4 hours. So this is the kind of thing that happens. So you've got these annulus rings, nucleus pulposus in the middle. You get little fissures, little fissures, little fissures, and then it can break through that final ring of the annulus. But what you'll find in a lot of the research that's out there, when they've taken samples of the material, it's not just the nucleus that is in the herniation. There's bits of annulus in there, there's bits of end plate, and there can be bits of bone. Okay, and depending on the material, it can often affect the this pain sensitivity as well. And there are some studies with that these kind of shards of end plate and bone may make the pain worse. Okay, so but again, there's loads of other factors involved in that. So it's you take that information, but you use it with everything else that we've got as well. So if it's a large herniation and it's coming out of the final stages of the annulus, then that can trigger the body's immune response. Because when it's contained within here, so it's just broken through a couple of the annular rings, the body isn't aware of it. But once it's come through, then the immune response can be triggered. And this is why if you have a larger herniation, it can often be reabsorbed quicker. Okay, so if you have a large herniation on MRI, rescan it in 9 months' time, a year's time, and it can have completely reabsorbed. Okay, the smaller ones that are contained within the disc will probably remain. Okay, so the bigger ones can get reabsorbed. So this is the terminology of what each thing is. So we use words like bulge and protrusion and herniation, but what does that all mean? And that's from this paper here, so lumbar disc nomenclature. So the explanation of lumbar disc pathology, basically. So disc tissue that extends beyond the edges of the apophysis throughout the circumference of the disc. So if you have a more than 25% spread of the disc, so if we have a look here, so we've got this bulging of the whole disc, more than 25% of the disc, that is called a bulge. Okay, so that's that's what a bulge is. Okay, so if someone says it's bulged, then that's what's happened. So if you have a look here, this would be a 50% bulge, but it's an asymmetrical one. This is a circumferential bulge. It's a diffuse one because it's all the way around. Okay, so if it's more than 25% of the whole disc, then that is a bulge. Now, a protrusion is less than 25%, and it's usually in a specific area. Okay, and then you have two what do you call them? Categories. So you have a focal protrusion, so something that's very focused, and then you have an extrusion, which is wider. Okay, so if you have a look here, protrusion, the focal protrusion, the base, which is the blue line, see the blue line across there, is thicker than the head, which is the red line there. So this is how they categorize them on an MRI. So if you have an MRI done, they say you've got a focal protrusion, then that is what it is. Okay, so the base is wider than the head, so which is the material that's been herniated. An extrusion, the head, so the red line there, is bigger than the base, the blue line. Okay, and that's basically just a category for MRIs. Yeah, so if you have a scan done and you notice that that is what it says on the MRI, then that's basically what it means. Okay, then you have a sequestration, which is a type of extrusion. And to sequester something means it's secluded, so it's apart from everything else. And if you have a look here, it's basically broken away. Okay, so you can see it's broken off and it can go into the spinal canal. And you'd think, oh, bloomin' heck, that's not good. But actually, these can heal really well because the body's immune system can break it down and get rid of it. So that these are often better to have, these sequestrations, it's easy for me to say, than some of the extrusions and protrusions. Okay, so it will, yeah, it's the opposite to what you would think. Then there's a final category. This is the last slide, I promise. Sorry about all these slides today, but I think it's necessary for this one. So you've got contained versus uncontained, and this is where it goes back to this ligament that we were talking about right back at the beginning of today. Okay, so this is the posterior longitudinal ligament down the back of the vertebral bodies that connects to the back of the disc. Now, a contained herniation has not broken through the posterior longitudinal ligament. It hasn't come through here. But an uncontained herniation has broken through the posterior longitudinal ligament. So it's come through. Okay, it's uncontained. Uncontained are surprisingly less trouble in the long run because the immune system can help with the clear up. Okay, so that's sequestration. I'm having really difficulty with that word. So that because it's separate and it's outside of that posterior longitudinal ligament, it can get cleared up by the body's immune system. Okay, and it's much more likely to get cleared up than some of the other protrusions or extrusions. Okay, cool. Hopefully that makes sense. Move that there. Okay, so there was a couple of questions. So when would a discectomy be indicated? Um, it's usually when there's a mechanical force that is pressing on a nerve root. So it comes out of the side of the so a posterior lateral bulge that impacts on the nerve root. So then you lose sensation and power. Usually they would do something drastic then, because if you don't get in and get that sorted quickly, you can permanently lose sensation and power to the limbs, because it will damage the nerve. That is the one that I know off the top of my head. I'd have to do a bit more research on when they would do it, but that's the one off the top of my head. I hope that helps. Cool. Yeah, absolutely. Yeah. Crazy to think they can break through ligaments. Yeah. Yeah, you imagine those structures to be really, well, they are really tough, but they can get through. Yeah, cool. So that's discs. All right. Hopefully that's kind of cleared a few things up. So you know when somebody says, "Oh, I've had a disc bulge," you know what that means now, or there's a protruding disc, you know what that is, and you can ask some further questions if someone says it's protruding. You say, "Well, is it contained or is it uncontained? Is there some kind of sequestration?" Got to practice saying that. Is the sequestration annulus or nucleus juice? It's a bit of both, and it can be a bit of end plate and a bit of vertebral body as well. Yeah, so it can be a number of different things. Yeah, it's all kind of mixed up together. And like I was saying before, I think depending on the structures, there are some studies that show if there's bits of shards of bone and end plate in there, then it's more likely to be painful. Yeah, so yeah, interesting stuff. Cool. I think the kind of take home message from all of it though is that if you scan someone with a disc bulge, especially one that's protruding, extruding, or sequestered, then it can go back in. Yeah, so it doesn't mean that they're stuck with that and then that's it. It can reabsorb, and even those that have had a big disc bulge or disc protrusion, disc extrusion, I'm saying it now as well, and they've got pain. If after they've been scanned and it goes back, they may still have pain. So it doesn't mean that that is what's causing their symptoms, basically. Okay, it can be, but it might not be. Cool, no problem. Well done, guys, for enduring that one. Yeah, if you've got any more questions, pop them in the group, and I'll try and put links through to things to if you've got any particular questions about some of the studies that I mentioned today. Then yeah, just give me a shout. I've put a lot of the references in the slides, so you can have a look at those and try and search them as well. Cool. Have a good day. See you guys.